be starting with Professor Shizuya Yamashita. He'll be talking about the Japanese and European trials. Please.
Thank you very much for your introduction. And I thank Ganshar, just he's coming here, so for inviting me to this very fantastic symposium. This is my first time to come to Africa, and of course Morocco. So I'm so happy to be here. And I want to present the data of the Japanese and European trials on pemafibrate. Oops. Okay, all of you know very well about the sperm alpha. So Dr. Furusho had developed a concept of this sperm alpha, selective PEEP alpha modulators. And because of the, some undesired effect of previous fibrate, so to exclude that kind of side effect, this sperm alpha was developed to the on-target genes, to accelerate on-target genes. And we don't want to accelerate these off-target genes. So this is a very selective for these genes. And previous data show that pemafibrate has a very strong affinity to human PEEP alpha compared with an active form of pemafibrate, like this. And compared to other PEEP gamma or delta agonists, pemafibrate doesn't have strong effect on PEEP gamma or delta. So that metabolism of pemafibrate is shown here. More than 73% is excreted from the liver into the bile. So, and even if there is some impaired renal function, the concentration of pemafibrate doesn't go up so high. This is good data for use. So we have organized a collaborative pemafibrate study group in Japan. Shun Ishibashi, he's not here today, but Shun Ishibashi has organized this group. And Yokote, this morning, Dr. Yokote presented some very interesting data, and he is one of our group. So recently, we have done post-marketing clinical study of pemafibrate in patients with renal dysfunction. We looked at the concentration of pemafibrate in very severe renal dysfunction, like this, including dialysis patient. So the concentration is not increased, even though in those under hemodialysis. So this means we can use pemafibrate in patients with severe dysfunction of kidney. And this is also Cmax. It is not increased, even if renal function is impaired. So this is the first data of phase 2 dose-finding study. Dr. Ishibashi and we published these data. When we used pemafibrate in a dose-dependent manner, triglyceride is reduced about 42%. And in comparison with fenofibrate 100 milligram, the reduction of triglyceride was more marked in pemafibrate group. Regarding the increase in HDL cholesterol, as you can see, there was a dose-dependent increase in HDL cholesterol, and nearly 20% or so, compared with 100 milligram pemafibrate. And when we plotted the relationship between baseline triglyceride level and percent change in LDL cholesterol, and if triglyceride is very high, like this, there was some increase in LDL cholesterol, as already mentioned. However, when triglyceride is not so high, there was a decrease in LDL cholesterol. There was a strong positive correlation between baseline triglyceride and percent change in LDL cholesterol. And this is a relationship between baseline LDL cholesterol and percent change in LDL cholesterol. As you can see, when LDL cholesterol is high, there was a significant reduction in LDL cholesterol. However, in those patients whose baseline LDL cholesterol was not high, there was a substantial increase in LDL cholesterol. There was a negative correlation between baseline LDL cholesterol and percent change in LDL cholesterol. And also, we looked at we looked at the remnant lipoprotein cholesterol level. This is measured by detergent direct assay. And as you can see, pemafibrate could reduce remnant lipoprotein cholesterol levels about 50%. So that was a marked decrease in remnant cholesterol. And this is a little bit complex slide, but we looked at LDL subclasses by using gel permeation HPLC, which can measure concentration of cholesterol, triglyceride, or phospholipid, or free cholesterol in each subclasses of lipoproteins. We divided 20 lipoprotein subspecies. This slide shows a change in the LDL subclasses. As you can see, large LDL cholesterol was increased, and medium LDL cholesterol was slightly increased. However, small LDL and very small LDL, that means small dense LDL particles, cholesterol, were decreased, as you can see here. And regarding the HDL subclasses, there was some minor change in very large HDL cholesterol, but almost no change. And large HDL cholesterol was not significantly changed. However, medium HDL cholesterol and small HDL cholesterol and very small HDL cholesterol were all increased dose dependently. This means very small HDL particles are increased by pemafibrate treatment. This is just contrary to CTP inhibitor. And how about is adverse drug reactions? Pemafibrate, each dose didn't show any increase in adverse drug reactions, including liver dysfunction, CK increase, or kidney function. No problem for these parameters. And this is a little bit complex slide, but this is very important for future studies. And as you can see, compared with placebo, AST was not significantly changed, but ALT was decreased like this in pemafibrate treated groups. And gamma GTP was also decreased. Alkali phosphatase were markedly decreased. And serum creatinine showed a little small, very small increase, but not so much compared with fenofibrate. And there is some increase, small increase in homocysteine, and a marked reduction in fibrinogen, as you can see, compared with placebo. So we wanted to use this kind of sperm alpha with statins. So this is the combined data of Japanese and non-Japanese. As you can see, we use each kind of statins, but there is no significant increase in pemafibrate concentration. And also, even if we use pemafibrate, statin concentration is not significantly changed. That means there is almost no drug-drug interaction with statins. So therefore, we can use pemafibrate with statins. So these are the data of pemafibrate on top of statins. We reported that pemafibrate reduced triglyceride levels about 46 to 60, 50% on the top of statins. And also, HDL cholesterol was increased about 16 or 70% on top of statins. And how about is adverse drug reaction on top of statin? As you can see, even if we use combination of pemafibrate and statins, there was no significant increase in liver dysfunction or CK levels or increase in creatinine levels. So this means we can use pemafibrate on top of statins. And these are the data of the ALT, time changes of ALT, gamma GTP, serum creatinine, and EGFR. As you can see, compared with placebo here, ALT and gamma GT were significantly reduced, and this was discontinued throughout the studies. How about is a creatinine and EGFR? There are only a mild increase in serum creatinine and a mild decrease in EGFR, but almost neglectable, I think. So this is a data of effect of pemafibrate on fasting TG levels in patients with type 2 diabetes. Similarly, as I mentioned, even in the patients with type 2 diabetes, we could get triglyceride reduction about 45%, and that was maintained throughout the study. And in this study, we did oral fat loading test to check the effect of pemafibrate on postprandial hypertriglyceridemia. As you can see, there was no significant change in placebo. However, pemafibrate 0.2 milligram per day or 0.4 milligram per day significantly attenuated postprandial hypertriglyceridemia. This means the increase in atherogenic chylomicron remnants is reduced by pemafibrate treatment. That means it may have a favorable effect on atherosclerosis. And this is data of the same study. Araki et al. Reported that in patients with type 2 diabetes, as you can see, fasting plasma glucose was reduced, significantly reduced. And fasting plasma insulin was significantly reduced. HOMA-IR was therefore significantly reduced. This means pemafibrate can attenuate insulin resistance and improve glycemic functions. And this is another study done by Matsuba et al. He did euglycemic cramp study and in diabetic patients. So pemafibrate increased splanchnic glucose uptake rate compared with placebo. However, pemafibrate didn't significantly affect peripheral glucose uptake rate, as you can see in the right panel. So this means pemafibrate can intensify the insulin sensitivity, suggesting that it may have a favorable effect on diabetes. And in this study, we also checked the function of HDL in diabetic patients. Pemafibrate increased ApoA1 levels and pre-beta 1 HDL particles and small HDL3 cholesterol. This means pemafibrate can transform large HDL particles to smaller one and also discoidal pre-beta HDL. So this suggests that pemafibrate effect on HDL may be very good for prevention of atherosclerosis. And we did cholesterol efflux capacity. We measured cholesterol efflux capacity in this model, in this patient. So pemafibrate could enhance the cholesterol efflux capacity of HDL particles after pemafibrate treatment. So how about the data in European patients? Phase 2 studies were done on pemafibrate for patients with statin therapies. So as you can see, statin plus placebos and statin plus pemafibrate 0.1 milligram QD and 0.2 milligram QD and 0.4 milligram QD. And we statin and pemafibrate 0.05 milligram BID, 0.1 milligram BID, and 0.2 milligram BID was also included. So we analyzed 7 groups of patients in Europe. So these studies were done across 9 European countries, as shown here. And in this study, the effect of pemafibrate on triglyceride is shown here. And I think a little bit small difference between QD group and BID group. So 0.2 milligram BID showed most significant reduction in triglyceride levels. And how about is a non-HDL cholesterol levels? I think there is a reduction in non-HDL cholesterol in each group, but there was no significant difference between BID and QD. And the remnant cholesterol is also reduced so much in BID group compared with QD group. And ApoC3 was also so much reduced by 30% in 0.2 milligram BID. And this effect was a little smaller in QD group. How about is ApoB 100 and ApoB 48? As you can see, there was not so significant effect on ApoB 100 levels. However, ApoB 48 levels were significantly reduced, nearly 36% in the BID group. Similarly, HDL cholesterol and ApoA1 were increased. However, compared with low-dose group, ApoA1 increase was not so much in 0.2 BID group, but there was some increase in ApoA1. And this is the data of total ApoB, means ApoB 100 and B48. There was some decrease by pemafibrate. And as I mentioned, LDL cholesterol was increased by this percentage. So about the safety of the use of pemafibrate on top of statins in Europe, there was no significant increase in the side effect, including liver function, creatinine, CK, and bilirubin or some others. There was no significant side effect. This is a pooled analysis of phase 2 and 3 studies in dyslipidemic patient with or without statin combination. And we compared the data of the patient with statin and without statins. As you can see, there was a little larger decrease of triglyceride in patients with statins. But this difference was not significant compared with those patients without statin. And in the pooled analysis of phase 2 and 3 studies, this is a change in HDL cholesterol, percent change in HDL cholesterol. And when statin was used, the increase in HDL cholesterol was a little bit less than those observed in patients without statins. So I don't know the reason yet. So this is data of Professor Yokote. This morning he spent a very good presentation. So this is a pooled analysis of 6 phase 2 and 3 randomized double-blind placebo-controlled trials performed in Japan. These are the changes in fasting plasma glucose from baseline. This is placebo, and pemafibrate 0.1 milligram, 0.2, 0.4 milligram per day. So as you can see, in all patients, compared with placebo, there was some significant change in plasma glucose level. Plasma glucose levels were reduced by pemafibrate treatment. And when we look at the patient whose baseline levels of glucose is more than 126, so the effect was more strong. So as you can see in this slide. How about is fasting insulin levels? And in all patients, compared with placebo, pemafibrate reduced dose-dependently plasma insulin levels, and especially whose baseline insulin levels was more than 15 units per ml, this effect was more marked, as you can see here. So therefore, HOME-IR showed good response by pemafibrate, and also especially whose HOME-IR was more than 2.5, it was more marked. And these data show plasma glucose metabolism may be improved through enhancing insulin sensitivity. However, as we didn't expect, but HbA1c levels were not changed, significantly changed compared with placebo group, like C. Yeah. And how about these changes in ALT from baseline? In all patients, compared with placebo, pemafibrate treatment dose-dependently reduced ALT level, and also those whose baseline ALT levels were high, that was more, pemafibrate showed a more marked reduction in ALT levels. Similarly, this is the data of gamma GT. As you can see, compared with placebo, pemafibrate decreased gamma GT dose dependently, and also in those patients whose gamma GT was more than 80 in males and more than 30 in females. As you can see, gamma GT reduction was more prominent compared with placebo. This is the data of ALP. Similar data were obtained. And even if ALP is very high, there was a marked decrease in ALP levels. So this is the data of FGF21 from baseline to week 12. As already mentioned by other speakers, pemafibrate could increase markedly the levels of FGF21, as you can see. This is a log formation. Similarly, pemafibrate could increase FGF21 levels so much. And recently, Dr. Nakajima of Yokohama in Japan did to look at pemafibrate on patients with NAFLD. So 118 patients were recruited who were corrected by NMR analysis by showing that fatty liver is demonstrated. So as you can see, ALT levels and AST was not changed. ALT and gamma GT and alkyl phosphatase levels were significantly reduced by pemafibrate. This data shows that pemafibrate may have a good effect on NAFLD. Creatine levels and EGFR were not changed. So this is very interesting to note. So they measured liver fat by MRI, PDFF, and liver stiffness by MRE. And contrary to our expectation, liver fat was not significantly reduced by pemafibrate treatment. However, liver stiffness was significantly reduced by pemafibrate treatment. And this may be related to the reduction of fibrosis-related genes. To summarize the characteristic features of pemafibrate, it is mainly metabolized in the liver and not affected by renal function. And pemafibrate shows little influence on renal function. It can be used with statins as it has no known drug and drug interactions with statins. Pemafibrate increases lipoprotein lipase, but decreases ApoC3, thereby activating lipoprotein lipase. Pemafibrate decreases triglyceride, remnant lipoproteins, and small dense LDL particles. It improves postprandial hyperlipidemia. Pemafibrate increases HDL cholesterol. So these HDL particles are very small and spherical, and also discoidal pre-beta HDL particles. So these HDL particles activate anti-atherosclerotic HDL function, including cholesterol efflux capacity. And pemafibrate enhances beta oxidation in the liver and decreases fibrinogen, and may favorably affect liver function and may improve NASH, NAFLD. And I think NASH study is going on in the world. It improves insulin resistance and glucose metabolism. Thank you for your attention.